Welcome on our presentation about the effect of smoking on bariatric surgical candidate outcomes. This is a propensity-score match analysis of the MBSQIP. We have nothing to disclose regarding this presentation. Smoking status is an important risk factor for surgical complication. It was described in many studies before. However, the effect of smoking within the last 12 months on the safety outcome of the most bariatric procedures, laparoscopic sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass, had not been estimated yet. We decided to use the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program datasets from 2015 to 2018 to describe differences in fertility complication incidence between smokers and non-smokers in two separate bariatric subpopulations: patients who underwent laparoscopic sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass. The definition of smoker in our study was current smoker within 1 year. Out of MBSQIP datasets, we choose using CPT codes all patients who underwent sleeve gastrectomy or Roux-en-Y gastric bypass. Then we applied our inclusion criteria, which you can see here, and we also performed something which is unique, a quality check, and we removed those cases where there were some doubts about the quality of records. So finally, we end up with 29,165 pairs in sleeve gastrectomy subgroup and with 11,895 pairs in Roux-en-Y gastric bypass subgroups. We decided to use propensity scoring because we wanted to minimize the selection bias. The decision was made because the primary outcome, the mortality, was a rare event. All-cause mortality was the primary outcome in our study. However, we also assessed the following secondary outcomes: readmission, reoperation, operative time, leak rate, bleeding event, and any medical complication within 30 days after surgery. Here you can see the results regarding sleeve gastrectomy patients. Smokers who underwent sleeve were older and have higher prevalence of COPD and GAD. However, BMI and the prevalence of hypertension and diabetes was lower in the group when compared to non-smokers. But after matching, the differences were no longer present between the analyzed cohorts. In this table, you can see the results regarding the outcomes of interest. The mortality was low and comparable between smokers and non-smokers. However, smoking in sleeve patients increased risk for leak, reoperation, intervention, readmission, emergency department visits, and pneumonia. When we take a look in gastric bypass patients, we found that smokers who underwent gastric bypass were younger and more likely have COPD and GAD. But their BMI was higher and the prevalence of hypertension, diabetes, hyperlipidemia, and sleep apnea was lower. But again, after matching, the differences were no longer present between both groups. And now, please take a look at the outcomes. of interest. The mortality in our study was low in gastric bypass patients and comparable between smokers and non-smokers. But in gastric bypass patients, smoking increased risk for leak, reoperation, intervention, bleeding, medical complication, emergency department visits, and readmissions. However, our study has some important limitations. First of all, in MBSQIP, there may be possible errors in procedure coding. Also, there is a problem because we didn't have data regarding indications for surgery. Of course, this is only observational study with short-term follow-up, and some technical aspects of the procedure were not assessed in our study. Of course, some variables available in PUF file does not allow for efficacy assessment. Our study shows that smoking within the last 12 months before surgery increased the risk for postoperative complications in patients who underwent laparoscopic Roux-en-Y gastric bypass and laparoscopic sleeve gastrectomy. The increase in risk was the most prevalent in the case of staple line leak or anastomotic leakage. However, it did not affect all-cause mortality. Thank you.